We did a survey before and we asked, what do you know about hospital home? What do you want to hear? And it was kind of divided into thirds. 1/3 didn't know much about it and just wanted to hear about the base components. 1/3 wanted to hear the up and involving technologies, AI, and how it's growing as a practice. And then 1/3 is like, I'm already there, but how do I scale? How do I solve the problems of today? What are the things that are going on? So we'll talk about all three very briefly. First of all, what is hospital at home for those beginners? It is inpatient care, what you get in a hospital, but in a different environment, in a different setting. It is the same treatment modalities, just done differently. And this is a key concept because a lot of times I hear, well, it's not hospital care. I went to the hospital, I'm sick, and you're gonna send me home, but you just told me I'm sick enough to stay here. How does that even compute in their head? And this is where the word different doesn't mean less. And you say, well, Mike, 2 is different from 3 and 2 is less than 3. So explain that more because I see it in my mind as I'm going home, I'm like getting all that stuff. The hospital has so many things that happen, but does it really? What is a hospital? What is hospital care? And it's kind of asking those who are religious, what is a church? Is it the building or is it the community and people in it? When it comes to a hospital, what is hospital care? Well, think about it. If you have pneumonia and you go to a hospital, what do you expect? And it's assessments, treatment, and outcomes. You expect somebody to see you and physically assess you. You expect to get antibiotics, usually through IV. It's not like you're going home and getting pills and that's it. You're gonna get something in the hospital that need to be given. And then there is monitoring, labs, other things that happen there. That's what happens when you have basic pneumonia in the hospital. Does that matter what that hospital room looks like? If it's a beautiful state-of-the-art room or a 150-year-old room at St. Mary's Hospital in Rochester, you're still getting the same care and you're still paying the same, your insurance is paying the same thing, whether it's brand new and open last week or it opened 100 years ago. Same thing, if your care team is a bunch of doctors, medical students, providers, learners, researchers, IT people who are doing rounds, or a very sleek, lean team that comes in and delivers that care. Again, as long as the outcomes and the care is the same, are you paying for the people or are you paying for the process and what you're getting? So if I got rid of new room, old room, this team, that team, and said, I can do it on your front porch with a lean team and you're gonna get the same treatment, same outcomes, is it less? No, it's just different. It's a different modality and there's advantages to that modality and that's the why behind hospital at home. And hospital at home has rules too. It's not like we can just put you in home and do whatever we want. There are things that go along with this. The patients have to be assessed, seen in a hospital ED or ward, made sure that they meet hospital criteria. They have to meet inpatient criteria. This can't be glorified home health or outpatient care. Patients have to be assessed daily by a physician or APP, either in person or virtual. They have to be seen in person at least twice a day by either a nurse or a paramedic overseen by a virtual nurse. And you have to have a rapid response system. You have to be able to get to them and do things like you would in a hospital ward if they got sicker and escalate their care back to a physical hospital or another building if they get that sick. Those are the rules of the trade. So why did we do this? Why did we start at Mayo Clinic? Why did John Rico Ferrugia say this is the future of medicine, or at least a large part of it? 1 out of 5 patients delirious, up all night, walking in the wards, having falls. People get weak in the hospital. 1 out of 5 patients go to rehab, not because of the illness that they had, but sitting in a room for 23.5 hours a day, not moving around for 5 days, and then you need rehab for that. Hospital-acquired infections kill thousands of people a year. Hospital errors kill hundreds of thousands of people per year. Capacity is a huge issue. We see it. We don't have enough beds right now to treat all the baby boomers, even if we wanted to. And even if we could build all those buildings at $3 to $5 million per bed, so $500 million for a 100-bed ward, not a good investment, we don't have the personnel to fill those beds to actually watch those folks. The cost of healthcare in the US is rising. You've heard about this all day today. 2 out of 3 Americans who file for bankruptcy is because they can't pay their hospital bills. That's ridiculous that you get sick and you go bankrupt because of illness. And patients will give up freedom and control for what they need, what we offer in hospitals. And they don't like them. As much as when I was patient experience officer, I heard this all the time. Isolation, food is terrible, I'm up all night, I'm stuck in bed. As nice as you make it, it'll never be home. So how can we address that? Well, how about we put them at home and do the same things there? Hospital at home's not new. It's existed throughout the world for the last 40 years in the US since the early to mid 90s when Dr. Bruce Leff started it. It was a model of doc in the box going home with a little carry case, a nurse at the bedside. It's evolved over time. And there's a lot of literature out about it. If hospital at home was a drug, it would be the best studied drug in the history of man. Multiple randomized controlled trials, multiple studies. Outcomes are very good. There are things that's not, trust me, it's not a perfect system, but people do better when they're at their home. Better recovery times, better mortality, less readmissions, decreased cost of care, we'll talk about that. A lot of good happens when you're at your home and everything's coming to you. So then you go, Mike, this sounds so great, and it's been around 20 years. Why the heck aren't we all doing this? Why is this not, the greatest thing in the world? Because it's really, 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 really hard. It's one of the hardest things to put together. And even at Mayo Clinic, doing it for 5 years, we're just hitting the cusp of actually scale and going up what we need to do. And most people are doing it. There's almost 400 hospitals in the US that have the waiver that are doing it. Most are doing it wrong. They make the fundamental mistake of saying, hospital at home is just moving exactly what I do in the hospital into the home setting. And that is wrong. That is taking something that is very inefficient and bad and moving it to a more expensive state outside your walls. You want to replicate what you do in general and the outcomes and what you can do care modality-wise, but not the process. If you're going to replicate the process, you're going to go broke in a year, and it's not going to be worth it, and everybody's going to be upset at you, and you're going to get fired. So don't do that. Hospital at home has evolved over the last 5 years. COVID did help a little with this. If there's a couple things good that came out of it. Version 2.0 moves away from docs making home calls to a new version, where the most expensive resources, the physicians, bedside nurses, move into a virtual state, use technology to connect to the patients and gather data, and then you build a supply chain, either with your own home health folks or you partner with other people who are not. Most of Mayo Clinic's vendors in the home are actually not Mayo Clinic personnel. You hold them to a certain degree of quality, you vet them and you work through this, but you actually partner with others to deliver your care. You enable them, you empower them, but you don't have to own it all. And that's how this works. Here's the 4 components in action. First of all, you have to get biometric data on your patients. So you have a way to connect with them with a tablet, you have devices at home, Bluetooth sending us data. This is the blood pressure, this is the heart rate, this is what's going on. Next, you have software. You need software to run home hospital. Anybody can run a home hospital of 3 to 5 patients with a spreadsheet, but you try to run 50 patients, one patient getting 1 bag of fluid. Pharmacy has to mix up the bag, somebody has to ship it there, somebody has to connect an IV, somebody has to do that for 100 patients with 50 orders each day. If you don't have software running this and organizing your system, you're never going to be able to scale with this. You have to have smart software driving this, and the perfect software has not been invented yet. So all of you entrepreneurs out there, listen up, this is where you can make some money. Next, you need to house your medical knowledge someplace. There's command centers. We have a physical command center at Mayo Clinic that oversees all our practice of virtual care, but it doesn't have to be physical in nature. We do that for teaming, but you can also have a virtual command center with people in different states just connected and talking virtually. But it has to be your people giving the medical knowledge out and dictating what care happens in the home. And then finally, the last component is the supply chain. We have to, again, have the capabilities of what we do in the hospital, labs, meds, the things you know, and then stuff that you don't think of. What do we do with medical waste? We feed people in the hospital. How do we feed them at home if they're hospital? You have to have all these modalities and offerings to the patients in order to deliver that type of hospital care in the home, but you don't want to do everything to everybody all at once because that's not what they need. What happens when you put these components together? Well, all of a sudden you have a system where you have to build your supply chains around your patients. I live in Jacksonville, Florida, where I practice Mayo there. I can't take care of patients in California with ambulance and personnel from there. But right now, today, I can see patients across the Mayo Clinic enterprise as a physician and as my nurse. We can see patients throughout the country where we have a supply chain at. That's all it takes. So your clinicians and your nurses, the highest cost resources, can see patients anywhere. And that's the scalability of the model and what we're driving forward with Model 2.0. So what happens with this? Well, I'm housed here, Jacksonville, Florida, just in case you didn't know where Jacksonville is. I understand you have an office there, so I was excited to hear that. I see patients on any given day in Jacksonville, but also in Wisconsin, Rochester, and in Arizona. So one clinician, multiple patients, one set of bedside nursing, multiple patients throughout the country, and then a key core of personnel, sometimes nurses, sometimes paramedics, that go to the home and do the in-home care that is necessary. Technology is advanced as well. We're doing neat things in the home to try to drive care and get labs back faster. So this is a portable lab unit. It used to be to get labs in our home hospital. Phlebotomists go to the house, draw blood, courier has to go pick it up, drive it back to Mayo, process in the lab. 4 or 5 hours later, I get, that hemoglobin's low, we gotta do something. Not anymore. Now some of these point-of-care labs are available. We can do drops of blood at the bedside, right, live with a paramedic in the home. Hey, Dr. Maniaci, hemoglobin says it's 4. We should probably do something about this. Okay, let's do something. Let's escalate care right away. So point-of-care labs really have helped out the system of driving care faster in the home. Medication release. You try to get a Tylenol to somebody with headache in rural Wisconsin at 2 a.m. when I'm in Florida, very, very difficult. Put in the order into Epic, have it processed through the pharmacy. Is a courier gonna pick it up and drive it out to the trailer park in Wisconsin where the guy's already had his headaches worse, he's thrown up, it's terrible. Devices such as this Medicube is almost like a mini Pyxis. This is a device you can load up with multiple medications, very secure. I've tried to beat one with a sledgehammer myself, doesn't break open. Put it in that patient's home in rural Wisconsin, 2 a.m., they get sick. My nurse in my command center pushes the button, drawer pops out. Here's your Zofran, here's your Tylenol. Take it, don't throw up, hope your headache's better, we'll assess you later. Devices like this are very helpful, especially for our patients with needs that that live far away in our supply chain. Monitoring. I showed you all those devices, blood pressure cuff, pulse oximeter. A lot of that's going away. We're getting advancements of wearable devices. Like when we have these wearables, as opposed to having a clinician go to the house and put on the blood pressure, or a patient trying to, well, how do I do this? Is it right? Does it go on the Well, just have this wearable device. You can wear it all day, 24 hours a day. It lasts several days with its battery. Stop for a second, Mr. Jones. Okay, I got your blood pressure. Go on about your day. Wearable devices are making progress as well. For our clinicians, digital devices, smart stethoscopes, portable ultrasound, how do we get data back, either synchronously in the moment or asynchronous? They record the breath sounds and I can listen to it 2 hours later and make a decision on what to do with the patient. Great resources for clinicians that want, how do you lose that? They're not at my bedside, how do I get that clinical data? Things like this are definitely helping out. You have to have a supply chain, so you have to have tracking, barcodes, GPS, ways to put this together to run your paramedics, nurses throughout your city. Those are being put together. And then drones, looking into drone delivery. Why drive 30 minutes? Nurses in the home, we need to place a catheter. We have the wrong catheter size. Darn it, we need a new catheter. You're gonna drive a half hour through traffic, try to get that there, or can a drone get that there in 5 minutes? That's the future. Drop it off. Don't waste the nurse's time, because that's your most valuable resource that's in the home. Have them get the new catheter, put it in. So drone delivery, I think, will help with healthcare, picking up lab work, bringing it back. The future is there for that as well. And then finally, smart technology, what I call the digital hug. How do you make a patient feel as safe when they're around the hallway in the physical hospital as they are 50 miles away at home? Smart cameras, smart speakers, smart Wi-Fi, things that create a protective shell around the patient that can alert us to changes in temperature, pain, heart rate. Those things get that peace of mind that a patient can have. Newer technologies, especially camera and smart Wi-Fi, will get that. I think that will replace a lot of vital signs. Even my wearable devices will be gone, and just by a watch and a camera in the room, I'll be able to get things on patients and know if they're deteriorating very quickly. All this stuff is coming technology-wise when it comes to hardware and making hospital at home easier. Speaking of AI, how is that helping us today and tomorrow in this process? Today it's helping with triage. So I treat patients, again, from 3 different states, 3 different Mayo Clinic hospitals, about 200 to 300 beds apiece. How do I go through all the, it used to take us 5 hours to figure out who's the right patient for home hospital, who's too sick that they need surgery or stay in the ICU, so on and so forth. Now AI can go through the Epic chart and say, hey, here's the patients. I can rank them all and say, these patients, knowing what you've taken care of in your last 7,000 patients at Mayo Clinic and a home hospital, here are the patients that can do really, really well in home hospital. Go see these guys first and see if they want to go into it from the ED and thing. Saves me hours of time. We used to take us 5 hours, now it can take us 20 minutes to triage and look at and find patients. Also, they're helping us with acuity. A 25-year-old with pneumonia and an asthma attack because of it requires just a few resources, a dose of antibiotics, maybe an inhaler, whereas a 95-year-old who has the same diagnosis might need a lot more because they're sicker, they have chronic disease, they may need home health care, something else going on. That's a big different thing. So pneumonia is not pneumonia when it comes to acuity. So now acuity ranking your resources, what we can do throughout the day. So I know I can take 15 regular sick patients, 10 super sick patients, or 5 critically ill patients in my home hospital based on number of paramedics, nurses, and resources. AI is helping us triage and bring to the forefront what does acuity need and the resources available to treat what you can in your ecosystem. And then finally, we're trying to develop AI algorithms to help actually push take that decision making, push it to the side with our clinicians. Meaning, blood sugar, we'll take this. This is an easy example we started with. Usually blood sugar nowadays, somebody takes their blood sugar, they write it in a book, and then they read that back to me, either virtually online or send it in to me. And then I make a decision with my clinicians, what do we do with that patient? It takes time and processes. But nowadays, you can put a few drops of blood in your glucometer that can electronically send those numbers to Epic. And then based off our 10 million endocrinology patients Mayo Clinic has seen over the last 100 years, it can say, this is what we've done for those 10 million patients. Let's electronically triage based on endocrinology's recommendations. This person's doing well. They just get a chat bot that says, good job, you're doing well, keep taking your blood sugars. These people need just a visit, but it can be virtual in nature, either an APP or a clinician, depending on the acuity. These people are really, really sick. They need to be seen in person. We don't have to do that ourselves. The technology, it's just like putting stuff into Wikipedia or up to date. That used to be a manual process, but there's no reason why AI can't weed through all the millions of patients, and that's why Mayo Clinic's building the platform is 10 million Mayo patients isn't enough. Let's go to 20 million with Mercy. Let's go to 30 million with somebody else. And if you can base off of best care off of that, then AI can help drive us the acuity and needs of what we really need with these patients. And that's exciting for us because that opens a whole new world. So why is scale so hard? Numbers 1, 2, and 3, change management. And this is the thing that really drives home hospital. We'll talk about in a second. Change management is the most difficult thing to make people be seen in the home setting. Delivery optimization doesn't exist nowadays, and we'll talk about that. The workforce, building the workforce of the future and how we're going to deliver care in the home or alternate environments is there, but needs to grow substantially. The regulatory environment is not friendly. It's getting better. There's been waivers and other things that have been done, but it's very difficult. And then finally, the payer model. It exists for home hospital, at least on the CMS side. In the commercial world, it's kind of out there. We play with it. And then anything below home hospital in the virtual care realm, very, very difficult when you look into the gray zones. So first, let's talk about change management and the biggest issue that I have with home hospital and why we struggle sometimes with scale. So the average bed count of most hospitals in the US is about 150 beds. When you look at those 400 hospitals doing home hospital, it's about 200 to 400 beds. Yet, our census is great compared to most. Usually a census of most home hospital programs, 5 to 10 patients if you're lucky when you talk to them, which is what, 1, 2, 3% of their bed count. Why so low? And when you look at the programs that are saying, we're doing so great, we have fantastic numbers, Mass Brigham General and Advocate Atrium Health, they're pulling from thousands of beds, and they may reach 60, 70, 80 patients, but still, it's still 1 or 2 or 3%. So everybody asks me the same question, and something I'm trying to solve is, what's the why behind this? And all that other stuff I'll talk about later is a little bit of the why, but really the why is this. And it goes back to what one of my mentors, Dr. Bruce Leff, talks about home hospital and the change management is, it is counterintuitive to anything we've ever done. This is Destin Sandlin. He has a video on YouTube. He's an advocate bicyclist, and somebody gave him a counterintuitive bike, meaning when you turn the handlebar left, it turns right, and when you turn right, it goes left. Sounds easy. He said, I could figure out how to do this probably in a week or so. It doesn't sound that bad. Took him 6 to 8 months to ride that bike. He fell over 100 times. Even now, he struggles. And he goes up on a stage like this in front of people. He says, I'll give you $100 if you can ride this bike across this stage. You just have to go straight. You don't have to turn. Almost nobody ever meets that challenge. Everybody falls. Even though you know you could just make it. But you do. And why? Because of this. This is his quote. He says, once you have a rigid way of thinking in your head, sometimes you can't change, even if you want to. And that's what the problem with home hospital is. Hospital at home goes against 100 years of what we've done. And breaking that rigid mold, even if we want to, is very, very, very difficult, and why we struggle with getting patients in at times. COVID-19, we had no beds. We had thousands of patients. What happens when you're under pressure? We had to do something. Then the pandemic disappeared, and we're like, well, that was nice. It's a nice thing still, but we don't need it anymore. But guess what? That pandemic is coming again. Baby boomers are getting older, and not enough beds, not enough workforce. It's a slow burn pandemic. It's coming. We're going to be in trouble. We got to do something. What makes this easier if you're a healthcare system? Who's going to succeed today in the world that's not optimized? A few things. First of all, if you have capacity issues, if you're bursting at the seams, it's a good model. Make a virtual ward for a couple $1 million. You can have a 50-bed virtual ward up and running, as opposed to $500 million to build 50 beds, which takes 2 years to do in any institution. Lower acuity works better. So if you have a lot of community medicine, small community hospitals, cellulitis, heart failure, exacerbation, pneumonia, easier than Mayo trying to do bone marrow transplants and kidney transplants and patients like that, much more difficult, higher acuity in the home setting. So if you have a lot of bread and butter in your ED and in your hospital, works excellent in home hospital. And then finally, if you're part of a health systems, if you have 4 or 5 hospitals around a city where you can admit from multiple hospitals to one home hospital ward, much easier than my one hospital in Florida trying to admit through its ED. I might get 10 patients in a day, great, but if I had 5 hospitals there, it would be 50, and my census would look much better. So healthcare systems can run with this a lot better than single institutions. Hospitals were built to why do we have hospitals? They're very inefficient because everything's in the same building. It kind of works, and the workarounds work. When you decentralize that, it all falls apart. Your workarounds do not work in a decentralized world. So that puts pressure on it, and people don't want to do it. Change fatigue. Hospital at home is one more, man, I'm trying to deal with so much right now, make ends meet, and you want me to build this home hospital thing? Why do I want to do that? Our hospital's working fine. Yeah, we have capacity issues. I can board them in the hallway. That's a lot easier than trying to invent a whole new system. Leadership buy-in versus leadership adoption. Oh yeah, we're going to do home hospital. It's part of our strategic plan. Are you going to give us resources? Are you going to give us credit for the value we add? Or you just want us to do this just so you have a selling point on a slide for your board? There's a big difference there. Clinical identity and perceived risks. How do I make my clinicians, accept this as somebody who's done something at the bedside for, 10, 15 years? Now you're going to do it through a screen. And guess what? I'm going to tell you that's going to be a better experience for your patient. What? Are you crazy? Are you kidding me? No. And then what I call the false comfort of inertia. Hospitals are flawed, but I know what I'm dealing with, versus the unknown of home hospital and this whole virtual care world. Why do I even want to get into that now? Especially if this guy who's an expert is telling me it's not perfected yet. I'm going to run into problems. It's going to be tough. Maybe I'll just wait and see what everybody else does. So you look at automated cars. One car, autonomous car, crashes anywhere. There's 15 news stories within an hour. There's people protesting. Everybody's complaining about it. We should not do this. It needs to go back to the drawing board. Yet in the United States, 44,000 people die every year of car accidents. That's 120 a day, 5 and out. 5 people will die, hopefully not in this room, of car accidents during this talk. And we go, it's just what happens. We accept that. But if this is going to be better in the long run, if autonomous cars are going to prevent those collisions and prevent those deaths, isn't that the right thing to do? And that's the way I argue about home hospital. Somebody will pass away if you see enough patients. It will happen, but that's part of hospital care. That's what we're doing. You have to be prepared for that. It can't be because you did something wrong or you didn't have the safeguards in place, but it's going to happen if you see enough patients. You have to win the patients too. You can't just win over the clinicians, the nurses, the doctors. You have to figure how do we talk to these patients and tell them it's the best for them. Education starts early. When I'm sick in an ED room, huffing and puffing because of my COPD exacerbation, I don't want to hear about home hospital then. And that's usually when we talk about it. No, this really needs to start in primary care. Hey, Mr. Jones, you have bad lungs. One day in the future, you may need to require, extra care that we can't give here in the clinic, or I can't do through a pill at home. But guess what? You could go to our physical hospital, or you could use hospital at home. Well, let me tell you about that and why the benefits from it, and here's some data and outcomes and what you could do, and we could set up with your family. That's a much easier conversation than trying to do it in the moment. Everybody has to be on board. It's not just the patients, but a lot of my no's come from family. Mom's sick. Well, we can get her home with home hospital. Well, it's tough on me too. What do I have to do? How's this? It's a little respite for me if mom gets out of the house. So, there's a negotiation that happens there as well. So but we don't want to take caregivers and put a burden on them and make them into nurses or doctors or something else. They can be integrated into the plan, but they can't be burdened by the plan. So we have to look out for that. Safety and convenience have to shine through. If it's not safe, if it's not a better experience, nobody's going to do it. And you only have one chance to make a good impression. And we fail at this all the time. I had a patient just a few weeks ago, young patient, under the age of 25, pneumonia, abscess in the lung, needed 5 days IV antibiotics, was in the ED, perfect patient for home hospital. Got them home that evening. I'm like, this is going to be great. Antibiotics didn't show up on time. Tablet didn't work. Parents were yelling at the machine. Nurse showed up. The IV was leaking. They couldn't get the IV to work right. The nurse said, I got to go to my next patient. Well, it's okay. You don't need any more doses. We'll deal with it in the morning. Patient came back to the hospital in the morning, needed a bronchoscopy, which was scheduled. Didn't want to leave the physical hospital after that. I've lost that guy for years at least until we make the system better. One bad experience, like a date. You make a bad impression, forget it. It falls apart, you're gone. And what will ultimately drive scale? We have to go from acceptable, yeah, that's nice, to preferable. There's a reason why you went from your flip phone to your iPhone. It happened to me around i4 or 5 or so around that. I didn't get it at the very beginning because I didn't need it. But then there was something that changed with technology that I said, yeah, I need to do email, I need to be connected with it. And that happens throughout our lives with all these type of transformations that we see. There's a day that things change from, yeah, that's nice, to that's what I should be doing because that's better for me. And once we have that with this virtual care ecosystem, then I won't have to do this talking about. I'll be out of business, which would be great because people will just be doing it because it's the way we do care. And that's ultimately what we want for. So how about delivery optimization? Getting things to the home when they're sick enough to be in home hospital. Why is that so hard? It goes beyond the software thing. This is not just about IT, it's about protocol, process. And people have asked me, why do most tech companies that get into this decentralized care delivery, especially home hospital, fail? It's because they have linear thinking. They look at home hospital like they're shoes from Amazon. There's a warehouse, it goes to a distribution place, it goes to a truck, and it goes at home. Great. But with home hospital, yeah, there's some linearity at front of medications and treatments, but then there's oh no, they're resistant to this antibiotic, we have to change from a once-a-day antibiotic to 3 times a day antibiotic. Oh no, the guy's also, he's in for heart failure, but now he has a rash on his leg. Who's gonna look at that? We're gonna start, do we need dermatology? The path is nonlinear, and the harder things you do, the more nonlinear it gets. And if people walk into this from a tech side and go, oh, it's gonna be easy, no. Why did Amazon start with books? It was easy. Books don't need any special packing, almost indestructible, don't need refrigeration, there's no regulations of them. If they show up a week late, nobody really complains. Had we done home hospital the opposite way and started with, let's do strep tests at home and go from there, it would have been a lot easier to build up this ecosystem. The problem is the super sick people would have to be escalated. So we started the hardest thing first. It's like Amazon would have started, instead of books, would have done kidneys. Now they need regulation, refrigeration, also they would have failed immediately. Within a month or two, they would have been gone. So we did it the hard way. It's not the right way, but we did it for the right reasons, to take care of the sickest patients around. There were capacity issues and COVID accelerated it, so that's why we did. But that's why the delivery optimization has to come. The future workforce, who's out there and what are they doing? Old jobs have to be done differently. Nursing, paramedics, physicians, training the virtualists of the future. How do you connect with patients if they're virtual? I've been doing them at the bedside for 20 years. How did I make that change in my mind? And I was asked last night at dinner, have you lost something not having that face-to-face, talk with the patient? And I said, well, actually, home hospital is a little more intimate than what I did before. Before, I ran down a ward of 15 patients in a row, stood over the bed, talked real fast, went to the next. Now it's me and the patient, one-on-one. They have to turn on the camera, so they have to invite me into their home. And then I see them, their dog, their family, what they eat, where they live. It opens up a whole new world. I learn about them, and I can have ownership. They have to take ownership of the plan to be part of this. So they actually take ownership of the plan. Their family takes ownership of the plan. And then together, we build the future plan for not just the hospital care, but what are you going to do after this? Because at discharge, it's here's your paperwork out the door for the physical building. Here we got some time. We have discharge on the horizon. We can say, oh man, I see in your home that you don't have a walker. You have carpet all over the place that you trip over 3 times a week, and that's why you hurt your knee. Let's fix that now before we discharge you, and all of a sudden it becomes better. So that's, we're building these new jobs, doing it differently. Paramedics, nursing staff working together, nurses, now virtual nurses overseeing the teams in the home. Jobs done in a whole new way, and training those jobs. How do you train the virtualists of the future? And then multi-purpose workforce. You don't want to send 10 people to do 10 hospital things in the home 10 times a day. You want to send one person to do 10 tasks once, because the other thing is very expensive and not efficient, and the patients don't want 10 people in their homes. No of you want 10 people in here. You want one guy stopping by once or twice a day, doing something, getting the labs, hooking the antibiotics, doing this and that, getting it all done. That's what you want, and that's the workforce that you need. And hospital at home doesn't live in a silo. I talk about home hospital, and it's the highest acuity model. But once you build this chassis of care, this decentralized ecosystem, you can do a lot with that. That's what I do with my paramedics too. We built hospital at home, which we call advanced care at home at Mayo Clinic. But next, we built cancer care beyond walls. That's chemotherapy in the home. I built stat care at home, which is urgent care at home, acute illness at home. So now my paramedics, who might have been seeing just a few home hospital patients, instead of seeing 2 in the morning, wasting the afternoon, seeing 2 in the evening, now they can see 2 home hospital patients, then go do a chemotherapy infusion under the supervision of a chemotherapy nurse, then 3 acute care visits, then back to the home hospital patients for the easy visit. You're utilizing resources properly. And you can build out the ecosystem. ED at home, chemotherapy at home, care hotel, this is post-procedural care. We had hundreds of patients sitting in our hospital wards as observations after getting a bronch or something of the sort. Not because they really need, if they lived across the street and their spouse was a nurse, you'd be like, yeah, go home, you'd be fine, I'll see you in the morning. But because if they're out of town or they're elderly, they're sick, I have nobody to watch them. During the COVID, we were going to cancel all these procedures. Instead, we said, let's put them all in the Marriott and just watch them virtually, and we can get to them if we need to. Worked wonderfully, and we still do it today. Who better to be at home with their parents than kids? Skilled nursing at home and having people recover in their natural environment, inpatient palliative hospice, other things. You can build off this ecosystem. It doesn't just, don't build for just home hospital, build for the ecosystem. The regulatory environment is fun. I think the major thing to talk about is the CMS waiver. This really empowered us to get paid for what we do and has driven some of the scale of home hospital across the US. It was launched in November 2020, the pandemic, which you all know and lived. What it did is it said you didn't have to have somebody at the bedside sitting there 24/7, and you could practice outside the walls of the hospital. It reimbursed us one-on-one with the DRG, which is what we need up front in order to make this work. We can talk about reduction of payment later. And then eventually it was decoupled from the pandemic, and it runs out in about 40 days. And that disappears, that payment model. There is legislation to continue it for 5 years. That's been proposed. It's sitting in front of Congress right now. It has bipartisan support because everybody benefits from this, rural, urban, old, young. There are CPT codes or revenue codes. You can bill for this. They put these out in 2022. It made it a lot easier for billing. So the process actually works for commercial and government payers. There's a lot of regulatory models. I'm licensed in 5 states because I practice in 5 states. Nurses are a little easier. They have like a combine they can join and belong to. They just make it hard for me. And what does it really come down to? It comes down to this. Everything I'm allowed to do in this building, I'm not allowed to do when I walk outside. Same thing for my nurses, my paramedics, everybody else. Care is tied to a building instead of acuity and job. It makes no sense whatsoever, but that's the way we built the rules back then, and we just have to change the rules. I was in Tallahassee. They didn't allow us to use paramedics in Florida when we first started our home hospital in 2020, so I had to go to Tallahassee and argue this. And the senators, Senator Bean, who was our advocate, is like, Mike, tell us why. And I was there with Peter Chang from Tampa General, like, we need this. They said, why should we allow you to have paramedics in the home? And I go, well, right now, if one of you drops because of a heart attack, who shows up when you call 911? It's a doctor? No. It's a nurse? No. Who? Paramedic. What do? They start an IV, they resuscitate you, they intubate you, they stabilize you and get you to a hospital. You allow that, that's fine for them, but under the virtual watching of a physician and a virtual nurse, they can't show up to a stable patient playing solitaire at home and hook up an IV and run some fluids. Does that make sense? Oh no. A month, they changed the rule, and we were allowed to use paramedics at home for that thing, because that's what we have to do. But all these laws are different and separate state by state. So we have to go through and change all these rules coupled to place, and now couple them to acuity, care, and skill set, licensing, so on and so forth. Difficult, but it can be done. Finally, how are we going to pay for all this? My CEO, Gianrico Ferruzzo, always says, every good idea should come with this sentence. This is a great idea, and this is how we're going to pay for it. Because if I don't have that statement on there, forget it, man. I'm stuck. I can shoot out good ideas all day, but it doesn't work if you can't pay for it. So there's different approaches. Direct payment models, reduction models, alternate pay models, 30-day bundles. We've talked about them all. I'm just going to give you a little taste of what's out there. And then for the last one, I'm going to take off my Mayo hat and tell you what I think about reduced payment models, so on and so forth. The value strategy is out there. People have talked about, well, there's a value to home hospital beyond just dollar for dollar, what you get within the walls or without the walls. And there's a lot of data. When you look at the data, chronically ill people that do home hospital, decreased readmissions, decreased discharge to skilled nursing, less use of resources of the community, less anxiety, less depression, discharge. People do well. And this goes on and on. Medicaid patients do better at home. So those with the lowest resources, and the ones that often take a long length of stay in physical hospitals, that drops off. Because all of a sudden you're assessing the home situation, you're making a state that's good for them to continue care. They don't feel like they need to show up at the ED anymore. They can connect to you and do this. Low socioeconomic status. Let's put Medicaid to the side and just say socioeconomic status in general. If it's low, if it's high, both benefit. So this is not just for the rich, it's not just for the poor, it's for everybody, and everybody benefits. And we look at ED, readmissions, when you look at government payers, again, I can give you data like this all the time. And this is all from doc visiting in the home. What about the virtual hybrid model? Mayo studied that, came out their study this year, showed that it is equal, if not better, to Mayo Clinic Hospital. What we do at home is equal to one of the best hospitals in the country. The data's there, again, that we provide value for this treatments in the long run. And there's more than just what we do. Finding out what patients need in the home and driving that care forward, reducing readmissions, they come back to the ED less, they report symptoms a lot faster. A lot of times they don't want to bother, I'm short of breath, I know I have heart failure, I'm not going to bother the doctor yet. We're going to see if I can get better on my own. I'm going to do some jumping jacks, take an extra Lasix. 5 days later, they're in their ED, huffing and puffing, need ICU care. Whereas with a virtual connection, they'll send that little text, they'll push the little, hey doc, I'm not feeling that good today. And we can catch more disease earlier with this virtual system and actually prevent that escalation to the emergency department. Better recovery, decreased use of sniff. We're looking at hospital-acquired infections, much amazing. When you take people out of cesspools at our hospitals and put them at home with their own flora, they don't have hospital-acquired infections, they're almost nil. It's fantastic. Capacity, again, $3 to $5 million to build one new hospital bed in a ward someplace where you're building. Let's open up that bed for somebody who really needs the physical building. And then for the patients, traveling 50, 100 miles to a clinic, to a hospital to get treatments, travel costs, hotel costs, all those things. All this is value that you can assign and give credit to or not give credit to. Mayo Clinic Hospital, we did an expansion in Jacksonville, just opened up this summer. One of the pictures, that pretty room was from it. We were supposed to open about 200 beds. We only opened up 120 beds because we said we're going to do 80 beds virtual. That was a whole ward that we just shelled off. That was another $50, $60 million we didn't spend. We have it in the future if we need ICU or ORs, but we didn't need it because we supplied home hospital, which was only a few $1 million to fund up front and push forward. That's the value. Now, will I get credit for that savings? I don't know. It's up to Jean-Rico and the team to say, yes, this is worthwhile. Even if I lose a few dollars over the course of treating patients, there's value to this in the long run. Accessibility and convenience. What's wrong with healthcare today? We've named many things, but it's getting care of the people. And the people that need it the most often can't get to it. So what do you got to do? You got to flip that paradigm, bring it to them, and do that for cheap and do it consistently with high quality. Barriers, they're there, but we can overcome them. And we can drive this forward. It's tough, but we can do it. So is it more cost effective? Well, yes and no, and I'll tell you. There's studies that have come out 10, 15 years ago. It was great, but it also handcuffed us. They said, look at this, we can save 40, 50% of hospital costs can be driven away with home hospital. Great, but then insurance came to me and said, man, we want to pay you 40 or 50% less if you're saving all this money. I said, well, let's look at what's really happening here. So if you look at what it costs to go in the hospital, about 50% of that goes to care, and then 50% goes to the other things that happen in the building. Building the building and its depreciation, waste disposal, chemical disposal, utilities, sanitation, all the stuff that happens. So what happens when you build a home hospital system? Well, you get rid of that stuff. All that stuff goes away. So yeah, this is where that 30, 40% number comes from. But that's not the real world. That's a 5-bed model where you just run off an Excel sheet. But if you're running a large home hospital system, you have a command center, you have a supply chain, you have costs there that add on to this in the real system that we're driving today. But when you compare them, there is this slight percentage difference. What our financial analysts looked at Mayo Clinic said, yeah, once we optimize the supply chain, once we get the right personnel, once you have the right patients and your volume's above this degree, there's going to be a 2%, 5%, 10%. There's something there to this. It's definitely cheaper in the long run. It's just not there today. We're not there today, but we can get there. And that's going to be a big deal, because if we can lower the cost of healthcare for everybody, even 5% of the trillions of dollars you spend, that's a huge number, and you can build upon that. Now, I want to do that, but I'd also like that money to go back to the patients and not to somebody's bottom line, so we have to do the right thing for the patients, driving down premiums and payment models and so on and so forth. 30-day bundles, we looked at this at the beginning when there was no waiver and we were starting home hospital systems, sat down with Florida Blue. This is the argument we had. Hey, here's what it costs you at Florida Blue to do home hospital versus traditional hospital. In traditional hospital, it costs X amount for, I just picked a DRG pneumonia. 1 in 5 patients gets readmitted. 1 in 5 patients goes to a SNF. Here's the average cost of all your patients, $19,000. With our optimized system, we can do that for $14,500, something of the sort. Let's meet in the middle. You pay less, we pay more, and we take on the risk. We'll own that patient for 30 days, and if something happens, the dollar sign stops with us. But we want to do this because we think there's a better model here. We've talked about this. This is what we've done with some folks and say, okay, this is how we should probably propose a 30-day bundle. But it can't be 30 days of hospital level observation and care. It has to be a nice tiered system where they have their home hospitalization, and then a step-down virtual tracking. You don't want a bunch of hospitalists watching people for 30 days because we end up escalating care at the drop of a hat. We're not that good at it. So there are ways to build this and pay for it and do it right. It's a system of the future, but again, you have to have that optimized system to make it work. And this is where I'll take off my Mayo hat, and many, many insurance companies come to me and say, Mike, we know there's a reduced cost in the long run. We want to pay you less because you're doing less. I say, no, I'm doing different. I say, no, but you told me you're going to save 10%. Can I pay you 10% less? They go, what are you going to do with the people in the hospital? We're going to pay them the same. And that's not going to work. And I'll tell you why. Because if somebody goes into the hospital and it costs the hospital $4,000 to take care of pneumonia, and you reimburse them $5,000, But at home hospital, which costs less, you're telling me, well, I'm going to give you less money for the same bundle of care. We're not talking about extravagant care. We're saying those things I mentioned at the beginning, assessments, labs, pneumonia, antibiotics. What is going to happen? Everybody's going to put people in the building. They're going to put them in hallways. They're going to put them in tents because administration is going to go, man, we want the extra $900. It's not unethical to put somebody in the hallway. It's terrible. It's not good for your HCAP scores, but we do it all the time for capacity issues. Unless you're totally overflowing with capacity, there are ways to move around this. People are going to want their money. So they're never going to pay less for the same thing. It's just not, that doesn't make sense in a two-tiered system. So paying buildings more for doing the exact same thing they do at home, it's not going to work. Instead, my solution, which my clinic doesn't like, but this is it, is you pay the same thing for basic care. So if basic pneumonia is treated by a physical or virtual assessment, IV antibiotics, labs, and monitoring, if that's all you need, you pay the lower price for that. You can do it in your building for higher costs and lose money, or you can do it at home for lower costs and make money, or break even. And that kind of forces the hand. Now, all of a sudden, hospitals don't have the incentive anymore. You've taken it away. It's controversial, and the Hospital Association didn't like me when I said this. So I said, well, wait a minute. There are reasons still to use the building. If people need, a bronchoscopy because they're an immunocompromised patient, if they need to go on positive ventilation, if they need advanced imaging for abscess like my young patient the other day, there can be extra costs for parts of care that you need the building for. And then people say, well, isn't that going to just push waste? Well, it theoretically could, but people have a less problem with putting somebody in the hallway and getting basic care. That's, again, it's a pain in the butt, but it's not unethical. Whereas doing a bronchoscopy when you don't need it, doing a CT when you don't need it, we've really pushed away against that as a medical community. We don't do care that's not necessary when it's invasive. You get cited for that. And we can have reviews of these things. That's what reviews are for. This is why we discuss this. So people will use hospitals in the future for surgery, OR, ICU care, high acuity care, decompensated patients, cancer, transplant, what we need. The rest of it, we need to drive home, but we need to pay that way so that I don't see an insurance company saying no to pay less for everything when it comes to basic care. I think anybody would take us up on that. But that's the only way it's going to work. Two-tiered is not going to work. I really believe this is the right way to do it or some form of it. We're going to continue to push forward on that. And with that, I say thank you. I know it's a lot of information, but I appreciate it, and we'll answer any questions.